Okay, let's talk about the coronary problems, and we're going to start with acute coronary syndrome. We'll talk about angina, stable angina, and stable angina and MI. And let's start with the stable angina. And from the name, basically, it means that it is not complicated. Now, just a little bit of angina. Angina, the words come from, it's a result of ischemia. This is a key word. Angina is caused by ischemia, which means that there is some perfusion, but it's not enough. And as a result of that, there is an imbalance between the myocardial supply and demand. Okay, so basically, whenever the body requires more oxygen as a result of increasing demand in metabolism, whether because of it's a result of stress or activity, the coronary arteries, when they're healthy, they should be able to compensate for this need. Now, if there is occlusion, partial occlusion in these coronary arteries, any problem in the coronary circulation, then that's when the patient will develop ischemia, when there is a greater need for oxygen that the coronary arteries are not able to supply the heart with, and then that will be manifested as pain or chest pain. So the word comes from the angre in Latin, which means to choke or strangle, and of course pectoris or pectus means the chest. Now let's talk about the pathophysiology. So basically, within the coronary arteries, there is an occlusion. This occlusion can be caused either by a blockage of a plaque or accumulation of atherosclerosis, or by spasm. So whenever this occlusion is 70% or more, which means only 30% or less of these blood vessels patent, that's when there will be an ischemia. Again, the supply of oxygen is way less than the demand of oxygen. So the cells will move from aerobic to anaerobic metabolism, and this will lead to an accumulation and production of lactic acid, which is very irritating to the nerves ending, and that's where the patients, why the patients start having pain that can be pressure or heaviness or sharp stabbing. As far as EKG, this ischemia is manifested by lack of rest in the myocytes, which is the T wave inversion. That is the diagnostic changes in the ECG that goes with stable angina, again with ischemia. Ischemia means the T wave is inverted, because you know the T wave represents a ventricular repolarization, and it's kind of resting period. So that's why the first thing that's affected in ECG when there's ischemia is that the T wave will invert, telling us that the heart is not resting. It's the heart is in stress as a result of decrease of oxygen supply. Now, again, the key word here is ischemia. It's not injury, it's not infarction. Ischemia means there's a lack of blood circulation or perfusion. It's not a complete obstruction. So usually there's about 75% that's being occluded, and or 70% that's lead to ischemia. And we talked about the pain. Now in ECG, it's a T wave inversion, and these are the classical symptoms of a stable angina. It's called a stable first. It's a predictable. The onset of it's predictable. We're going to talk about the location in a second. It lasts less than 5 minutes, and also it responds to nitroglycerin. This is important. This is the characteristic of pain the patient reports. Usually something causing it increase the demand of oxygen, either activity, emotional distress, physical stress, but it definitely the response to rest or nitroglycerin or both. So usually just if the patient rests or if the patient takes one pill or two or a maximum of 3 pills of nitroglycerin, usually actually one is enough, and that's where the symptom or the chest pain is subsides, and that's why we call it stable angina, because it can be stabilized. Now remember that there is a gender difference or differences between men and women as far as the presentation of the symptoms, and you want to keep that in mind. Women, they may manifest like an upper GI symptoms that could actually be an MI. So that's why now the practice in the ER, if you have a patient with risk factor for cardiovascular system who's complaining of epigastric pain, you need to do an ECG, not just treat it as an abdominal problem. Now these are the common locations. Again, it has to do with the nerve, and then so this pain radiates usually to the left side because of the nerve pathways. It goes up to the jaw and maybe back to the shoulder. This is the classical presentation of chest pain that's called by ischemia. The diagnosis first we'll do with a history. We need to obtain information from these patients about the chest pain. Again, chest pain doesn't mean always cardiac, could be non-cardiac. So we need to obtain more information from the patients. The patient's history mainly will depend. We're looking for risk factors. So when you have a patient complaining of chest pain that's constant, and the patient has high libido or has high blood pressure or his age is 65 or older, these are all risk factors to make us believe that this is probably coronary or probably as a cardiac chest pain. Now in ECG, as I said, the ischemia is manifested as a T-wave inversion. Now we talked about stress test as part of the assessment, and so if the patient comes with a stable angina after nitroglycerin is now there's no change in ECG and there's no chest pain. Now before we send the patient home to decide if we should keep them or put them in medication or not, we simulate the stress that the patient may have whenever they're at home or at work, and that's when we do the stress test. Based on the stress test, if the patient starts to show symptoms of ischemia, then this patient needs to be a nitroglycerin. We give them nitroglycerin to use PRN. Now, another intervention we can do if we believe it's more of unstable angina or maybe more, we need to see exactly what's going on. We do what we call percutaneous coronary intervention, which is like cardiac cath. As you see in this picture, we talked about the cardiac cath earlier to evaluate the structure and the function of the coronary arteries, and this way we can decide or we can see if there's any blockage or in the coronary arteries. And usually the report from the cardiac cath tells you exactly how occluded each coronary artery is. And again, symptoms they don't start if there is patency more than 30%. So when you have a patient who comes with angina at the hospital, we have MONA, and I add S for severance. So MONA stands for of course, morphine, and aspirin, and nitroglycerin, and oxygen. And I put it in the weight based on the pathophysiology. So we know that there's a coronary inflammation, is a platelet aggregation, and that's what's causing the occlusion. So the aspirin, not aspirin, again, this is autocorrect. Aspirin is the drug of choice for this platelet aggregation. So when a patient comes, we have the range of the dose could be from 81 milligrams to 650 milligrams, depends on the patient's weight and age and kidneys. And then after that, we may have to put the patient on aspirin daily of 325 milligrams. The other problem is that the decrease of perfusion. Remember, there is spasm or obstruction. So in order to increase this perfusion, we need to dilate this coronary arteries. And we talked about nitroglycerin to be one of the major vasodilator, and it is the drug of choice in this case as far as vasodilation. This is the drug of choice, nitroglycerin. For hypoxia, you want to give oxygen, and for pain, we give morphine. Morphine also relaxes the blood vessels, and that will decrease the resistance in the blood vessels, decrease the systemic vascular resistance, and make the the afterload to be low, which means there's less work on the heart. And then we want to keep an eye to see if there's any complication. Stable angina could complicate and could change to unstable angina or even MI. So observing this patient is extremely important. That's as far as the medical management in case of emergency. After the patient is admitted, we keep an eye on them, stabilize them. We may need to do a stress test. And it depends on what's going on. There's a wide range of intervention we can do. Through cardiac catheterization, we may put a stent for this patient, and some patient may need even surgery. Now, again, these are the considerations as far as medication. Morphine, again, this is you want to give it IV, of course. We have morphine available, PO, but in this case, we want a quick relief of pain. Again, the pain is gone, and also it relaxes the whole body, so the metabolism will relax, and there will be less need for oxygen, so that will decrease the stress on the heart for more oxygen demand. And also, as I said, it relaxes the blood vessels, so decrease the preload and the afterload. Oxygen, again, it will depends on the saturation of the patient, respiratory rate. For nitroglycerin, again, the common dose that we have is 0.4 milligrams, and we give it sublingually. Remember, this must be given sublingually. It's available IV, but we can start with sublingually. It's 0.4 milligrams. It's not. You ask your patient not to swallow it because it doesn't work in the stomach. It has to go and we need to do a quick vasodilation. So sublingually, it will be absorbed by the systemic circulation through the major blood vessels under the tongue. Now we can repeat the dose every up to 3 times every 5 minutes. And after the 3rd time, if the pain is not responding, then we need to do more interventions. Now we have also nitroglycerin is available IV. We can do it as a drip, and also it's available as patches that we can put on the chest wall. As far as the drug interaction, this medication can interact with Viagra. So if the patient has taken Viagra within the last 12 hours or 24 hours, we want to be very careful, because a combination of these both medication can lead to severe hypotension. Now remember that the nitroglycerin is a vasodilator, so the side effects will include hypotension, so you want to keep an eye on that, and you'll have to stop nitroglycerin if the blood pressure goes below 90, systolic 90. Also, it dilates all the blood vessels, so it dilates the cerebral vessels, so there will be more blood going to the head and to the brain, so the patient may complain of chest pain, of headaches. So the 2 major complications or side effects of nitroglycerin are hypotension and headaches. Now the hypotension, when it becomes severe, become adverse reaction more than side effect. As for aspirin, again, it's a chewable, it's non-enteric, and you ask the patient to chew it again because we want it absorbed as soon as possible. And we want to keep an eye on all the possible complications of angina. Okay, now you learn about nitroglycerin before, I guess that's, remember, okay, every time you see a medication, every time you see a medication that's in a brown kind of glass like this, know that it is sensitive to air and to light. So this is a photosensitive, meaning if you put this nitroglycerin outside in the air, it will become deactive. So you need to teach your patient about that. So you will see in the hospital sometimes IV medication are put in the a brown bag also. It's for the same reason. Okay. Now the management, the follow-up management, again, we will apply MONA every time is needed. These patients, we want to decrease all kind of side effects and all kind of risk factors that can complicate the cardiovascular conditions here. So especially if the patient needs, and this patient must be in bed rest, because we want to decrease the oxygen demand and metabolism demand. So we need to put them in low molecular weight heparin. So again, we want to decrease if there's constipation, we want to treat that. We want a calm environment, no sneezing. We want to again decrease all the activities that can increase the oxygen demand. Okay. Okay. So for patient education, again, you want to educate them about nitroglycerin, about storing nitroglycerin, because it's, as I said, it's photo and air sensitive, and about trying nitroglycerin 3 times and then calling 911, never to drive or have a family drive, then they have to call 911. Nitroglycerin must be kept in a dark and airtight container. And the way to know that it is actually it's still working, the nitroglycerin has like a slight a burning sensation if you put it on the tongue, when the patient put it on the tongue. This is just a way to test for them if they want to know if it's effective or not, it's still working or not. Avoid the Valsalva maneuver and modification of the risk factors. So anything that causing the patients or serving as a risk factor, patient needs to avoid, whether it's salt, or is it medication, or smoking, or alcohol, and so on. Now, the unstable angina, from the name, simply it's the kind of angina that does not respond to nitroglycerin or to rest, and also it starts at any regardless, so whether a patient is at rest or doing something. So it could be a stable angina, or whatever used to be a stable angina, now it progressed. And usually this when the patient has a thrombi that is not, or like a black or disrupted black that's not stable, was not stable for a while, and now got dislodged and went and closed one of the coronary arteries. So that's why the patient probably, as I said, maybe there's a black blocking 70%. It was a stable angina, but it continues to grow, and then at one point disrupted, and now it's closing one of the coronary arteries by maybe 100%. As far as the consequence, the ischemia and the pain is the same idea, moving from aerobic to anaerobic. And you may see a T-wave inversion here, but it also may lead to ST depression, something you can see in unstable angina. And so again, it's not predictable. It may wake the patient up, patients are sleeping, and now the pain may start. Location is the same. It lasts longer than 5 minutes. It's more intense, and usually it does not respond to nitroglycerin or PO when we have to put the patient on a drip or take them to cardiac cath. So again, there's a black. At this point here, the patient may be experiencing stable angina. Now the black ruptured and now forming thrombi or thrombus, closing more of the coronary arteries, leads to a complete or almost complete occlusion of the coronary arteries, and that serves as a severe edema. So the occlusion is large enough, even if you give nitroglycerin and try to dilate the blood vessels. It's still, the perfusion with the dilation is not enough, so the patient will continue to complain of pain. And as far as ECG, it could be beyond ST elevation. Now, there are a couple of different types of angina that we're just going to go over as far as the concepts. Variant angina, the highlight of this type of angina, it caused by a spasm. Usually the patient may not have any atherosclerosis or maybe have normal lipids profile. So it has to do with the spasm. And this spasm is induced by usually alcohol or drug abuse or heavy smoking. Patient may show ST elevation rather than depression in variant angina, but again, what is classical about it is that it's caused by spasm, and that spasm cannot be seen. Of course, it must be through cardiac cath, but it depends on the history of the patient. If the patient has a history of a drug abuse, and if this angina cyclic happens at the same time every day, even at rest, that's another classical thing about variant angina. Again, it's considered type of unstable angina because it lasts longer and usually it doesn't respond to nitroglycerin, or at least one or two of the nitroglycerin, where we have to put the patient on drip. And also because it's a spasm, we may have to use calcium channel blockers, which is the drug of choice to relax the blood vessels when there's a spasm. The other type of angina, the other type is the silent angina. From the name, this is an angina that doesn't cause the patient to complain of pain. And it is not different as far as pathophysiology, it's the same. The only difference is that the patient's nerves are not intact. So a patient has an autonomic neuropathy, so that the nerves within the heart that responds to the stimulation from the CNS is not working, and that's why the patient may have symptoms like on a chest X-ray, you may see a T-wave inversion that indicates angina, but the patient doesn't have pain. But instead, patient may become diaphoretic or complain of nausea and vomiting. Okay, so that's as far as angina. As far as MI, now infarction means necrosis. So far we covered ischemia mainly, or severe ischemia, and stable and unstable angina. In order to call it infarction means that necrosis means that some of the myocytes died as a result of the lack in the perfusion. So there's a death of the tissue. And again, this when there's a complete obstruction of the coronary artery circulation. So this complete obstruction, as far as ECG, you may see it as an ST elevation MI, and it may not be ST elevation. So it may and may not cause ST elevation. And the other thing, it may and may not cause acute wave abnormalities too. We will talk about ECG next week, but ST elevation, keep that in mind. ST elevation is an indication of injury, myocyte injury. Okay, and a Q wave, when the Q wave become long, it's an indication of MI, infarction or necrosis. Okay, I will pass this because I'm going to talk about it more next week. Okay, this is the ST, this is the normal ST. The ST should be a straight line. There's no electricity going on between the time of when the ventricles contract with the QRS and when the ventricles are relaxing, which is T wave. But the elevation, the ST elevation here, it's an indication of pathology, which commonly caused by myocardial injury or myocardial ischemia, myocardial infarction or injury, as well as the ST depression also. So it could be one or another. For the Q wave, again, this is a normal Q wave, should not be more than one small box in the ECG. If it's become long, that's a very serious indication. If the Q wave is long and the patient's complaining of chest pain, there's no question that this is an MI. So as far as pathology, again, it could start with ischemia, doesn't revascularize, severe injury, and then complete obstruction that can lead to death of cells. Okay, so quickly again, ischemia, zone of ischemia, that's when you see a T-wave inversion in ischemia only. And in injury, when there's injury, you will see an ST changes, and then in case of infarction, that's when you see the Q wave become long. Now, the kind of MI, now there's different wall of the heart, and then so the problem could be in any of the coronary arteries. So on the ECG, we can tell which wall is being affected. And you can think of this 12-lead ECG as 12 cameras or 12 shots. You put them together and it gives you a full picture of what's going on the heart, from the anterior to the posterior to the lateral, inferior, and so on. Again, I want to postpone the everything has to do with the ECG until next week. Okay, now as I said, MI can also cause an ST elevation or change in ECG, and also may not cause that. And it's still an MI. So the question is, what is the bottom line? How do we diagnose MI if it's not ECG? For many years, we followed ECG, and whenever we see an ST elevation, we treated it and diagnosed it as an MI. And if we did not see an ST elevation, we consider it not to be an MI, which was a wrong practice. Today, the bottom line is the troponin. So ST can support the diagnosis, but the absence of ST elevation, for example, does not rule out myocardial infarction. It could be a myocardial infarction that's not causing an ST elevation. So that's why we must do a troponin, and troponin is the diagnosis, is what we follow to diagnose. So this is an ST elevation versus a non-ST elevation MI. As you see, there's no complete obstruction here, but there's a complete obstruction in this heart. So let's talk about the diagnosis. Of course, first of all, we want to know the history of the patient, all the risk factors that the patient has. And then the physical examination here, you want to focus mainly on the cardiac, and we covered what we would expect to see. Mainly you want to focus on a chest pain. Now, this patient, as soon as you have them, you want to put them on a continuous cardiac monitoring. So if they're in ER or if they're in ICU or if they're in telemetry, we have to have a continuous and 24/7 cardiac monitoring to see how their ECG is. Again, 12-lead ECG is the first non-invasive test that you want to perform to see if there's ST elevation or any kind of ECG changes. Of course, the biomarkers and a troponin is the most important one of them, and we may need to do any of these tests. I mean, CBC can tell us if this patient has anemia. The PMP, definitely if the patient has heart failure, we want to see if this heart failure is causing the MI or vice versa. We want to see in a PMP if the lack of perfusion is affecting the kidneys. We want to see if their lipids is the problem and they need to take medication to lower their lipids so we can manage their risk factor this way. Chest x-ray also is important to see the size of the heart. If the patient is stable, we may need to do the stress test just to simulate the stress and see how the heart will manage next time. And then the patient may need to go to a cardiac catheterization, and then we may need to insert a stent. Depends on what we find as far as occlusion. Okay, you cover that. Okay, again in T-wave, if it's the T-wave inversion, that's something you see it in ischemia. ST elevation, you may see it more in MI or unstable angina. Q-wave, you only see it in necrosis, which goes by MI. And again, we talked about this earlier, and we talked about the troponin as CKMB. Again, what we will do, as said, we'll repeat the troponin every 6 to 8 hours for 24 hours, and if it keep going up, then that's when we confirm the presence of MI. Okay, we will discuss this in the class. I want to make sure that you understand all of these tests and how they affect the heart and what's their normal values. Okay, so again, just a summary of the management. When you have a patient with a stable angina, usually you don't see any, their ECG could be normal, but the worst you can see is an ST and T-wave inversion. There is no elevation in the troponin because there's no injury, it's just an ischemia. And usually the management just rests and monas. If it's unstable angina or non-ST elevation MI, you may see ST elevation, ST changes in depression in unstable angina, but you only may see also it's not. In other words, ECG is not specific. The biomarker, usually it's stable and unstable angina. Again, as long as there's no infarction, the troponin should be fine. And in case of non-stable angina MI, the troponin will be elevated. In simple words, MI means the troponin is high. If the troponin is not high, it's not MI. So the patient will need to rest. We need to give the monas, but this time we may need to give the nitroglycerin IV, and we may have to start the patient on heparin. In case of ST elevation MI, that's when you see the ST elevation. You may see the pathological Q wave as a result of infarction. Definitely troponin will be high, and in this patient we may need to use the Fibrinolytic Therapy or take the patient to a cardiac cath or use heparin if the patient is not candidate for fibrinolytic therapy. So the fibrinolytic therapy is like a TPA, dissolve the clot, and this is the best treatment. However, not every patient is candidate for it, so that's why we have other options. Okay, so again, either the TPA or the other products, or we can do PCI. Now, sometimes we have a patient again who's not candidate for a TPA, or the hospital doesn't have a cardiac cath, so at least we can treat the symptoms, and this will include giving the morphine and oxygen and aspirin, and also start the heparin drips. Remember, that's the heparin drips just to prevent another MI or another thrombi from being formed. Now, just quickly over the TPA, I'm just going to give a brief description because this will be covered in critical care, because you're not going to see this in your rotation. But again, these medications are given to dissolve the clots. This is the only, we talked about it when we talked about PE last week. But the concept I want you to keep in mind that we have a criteria, an eligibility criteria. Not everybody is candidate for it. Now, this medication is a very powerful blood thinner. So any patient with risk for bleeding should not take this medication. So if you look at this eligibility, you will find it that has to do mainly with the bleeding and confirmation that this is an MI. It must be an MI. Okay, so we shouldn't wait more than 12 hours of the onset. We must confirm it with ST elevation. We don't give this for a patient with non-ST elevation. Any risk for bleeding, a recent surgery, taking Coumadin or any of that can increase the tendency, we will not give this patient this treatment. So the common agent that we have is TPA and RPA and streptokinase and TK9. So again, the goal for using this therapy is to open this occluded artery or coronary arteries as soon as possible. Okay, so the mechanism of action is that it does the lyse the clot, and definitely you want to be careful and monitor for bleeding. That's the major adverse reaction of TPA. So if you start TPA and the patient start to bleed, or you start to see symptoms of internal bleeding, then you have to stop this medication. And we follow it by heparin again to prevent another clot from forming, and then the patient will need to take aspirin for the rest of their life. Okay. Okay. Now, if the patient is not candidate, then we have to do cardiac cath, and I shared with you earlier all the precaution and the interventions that you have to do before and after the cardiac cath, as far as teaching consents and what to prepare your patients to what to expect during the surgery, so during the catheterization, and also the post-op or the post-procedure interventions, and mainly the hydration and the pressure, and keep the leg straight. These are the different options of for a pressure to prevent the bleeding. So we have the sandbag, we have the fumostop, which basically it's like a little foam bag or foam ball, and it has a pressure meter, so you can increase the pressure, and it goes around the patient, underneath the patient. Also, we have this option, which is a collagen block that we can inject just after we finish the cardiac cath, and that will minimize the time that the patient will need to keep their legs straight. Now, again, this is a reminder again of the anticoagulant, what the patient will take. Again, this is for a patient who cannot take a TPA, we can treat them with heparin drip, and we need to you need to be able to calculate. We'll talk about this in the class. And remember that PTT is what you would be looking for when you administering heparin. And we can use a low molecular weight heparin like Fragment. And we have Aggrastat, another medication that we can give also if the patient cannot receive any of these. Okay, sudden cardiac death. Simply, what we mean by this is the death of the ventricles. Okay, see, when we talked about heart failure and heart functions, we really means the ventricles. So there are some conditions that affect the contractility of the ventricles. And the contraction of the ventricles is manifested on the ECG as QRS. So there are some conditions, maybe a problem in the structures or in the perfusions, or it could be because of medications, that affects the contractility and make it wide QRS, and that lead to a lethal dysrhythmia that affect the ventricles, like like ventricular fibrillation and ventricular tachycardia, and that can lead to death of the heart or cardiac arrest. So regardless of the risk factor that the patient has, there's a left ventricular dysfunctions lead to lethal dysrhythmia, and that can lead to cardiac death, where a patient you have to do a complete in like ACLS and cardiac resuscitation. So the major thing here is to know who's at risk. Okay, so any patients with dysfunction in the heart itself, so heart failure or MI or CAD, any of these patients can become at risk for the sudden cardiac death. But again, what it is mainly, it's a ventricular dysfunction, and that will affect the rest of the body. So the symptoms that you will see are mainly just like a heart failure symptoms, and a fluid congestion, and a new murmur can be a very serious symptom. So again, the best diagnostic test for this patient to know who is at risk is the ECG, and in the ECG what you will see is that the QRS is getting longer and longer, and that's just to give you an indication of the ventricular dysfunction. So any patient with a prolonged QRS should be treated as at risk for sudden cardiac death. Again, when we talk about ECG next time, I will touch base on the QT and the QRS and how to measure what do you mean by a wide QRS. For these patients, again, they may manifest sign of MI, so you may see a troponin if MI is happening at the same time. Again, in ECG, you will see a prolonged QT. Now, there's some medication that you need to be familiar with that increase and prolong the Q. So maybe there's no problem in the heart itself, but some medication that's when we test the patient for, like cocaine, for example, they prolong the QT, which means they slow down or they weaken the contractility of the ventricles, and that's basically what leads to lethal ventricular dysfunction or ventricular dysrhythmia, and then eventually cardiac arrest. Also, hyperthyroidism may also cause that. Okay, so it's all about the prolongation of the QT. Now, again, this patient must be in ICU, so if treated as a high risk for cardiac arrest at any time. Now, what you could see in this patient, you could see cardiomegaly. Again, especially if the patient has a long history of heart failure or cardiomyopathy, and as a result of that, the ejection fraction will be low again because the ventricles are weak, and also the ventricles you may see a change in their wall because their thickness changed also. Okay, the echocardiogram is the test of choice in this case to show where the ejection fraction, usually ejection fraction is low, and also the wall will become thick. And again, this is something you will see in patient with a chronic heart failure or chronic myocardial infarction. So the major thing that we're looking at, which we'll talk again about it next week, which is the VTAC and a VFib. These are two lethal rhythms. And the only medical treatment for it, if the patient is full code, is to do a complete ACLS. Also, putting a pacemaker could help for this patient if we find them on time.